Okay, so when we're thinking about what types of reversible causes can contribute to cognitive impairment or dementia, the term dementia can be useful in applying to it. So things like drugs, which we'll talk more detail about, eyes and ears, difficulty seeing or hearing, metabolic disorders such as hypoglycemia, emotional challenges, so things like depression, we can see what we call pseudodementia there. Nutritional deficiencies, a lot of times we'll test for folic acid deficiency, B12. We may see people who have hyponatremia or low sodium present with some cognitive impairment. Our T's are tumors, traumas, and thyroid. So brain tumors, brain trauma, thyroid illness. Infection, particularly in our older adults, urinary tract infections can contribute to delirium and cognitive impairment. And then alcohol, long-term use, as well as withdrawal can cause some symptomatology. Now, when we're thinking about medications that may cause cognitive dysfunction, CNS depressants and anticholinergic are like kind of our big players when it comes to contributing factors. So agents that may contribute include tricyclic antidepressants, which can be used for a number of different things, including sleep, pain conditions, depression, anxiety. It's recommended to try to utilize things like our selective serotonin reuptake inhibitors, except paroxetine, which is anticholinergic, SNRIs, like serotonin norepinephrine reuptake inhibitors, bupropion. First generation antihistamines in general don't have a lot of therapeutic use anymore because we have our newer products that have a better adverse effect profile. So cetirizine, fexofenadine, loratadine, if someone's treating seasonal allergies, we should be recommending those over our first generations. Muscle relaxants can have some significant impairment associated with them. And if possible, using things like our over-the-counter Tylenol or acetaminophen, NSAIDs, heat, ice is preferred if we can. Benzodiazepines for anxiety, we can use things like buspirone, and then our antidepressants, our SSRIs, SNRIs. Esopiclone, Zaloplan, Zolpidem, those are our Z drugs. They're sleeper medications. We like to try to use less sedating, less hard to tolerate products if possible over our Z drugs in our older adults. So low-dose trazodone, low-dose doxepin, which is less anticholinergic, Ramelteon, which is a melatonin type product, and melatonin itself. Barbiturates aren't used very often, but do have that significant CNS depression associated with it. And again, if we're using it for sleep, thinking about those alternative products. For nausea, as an antiemetic, a product like promethazine is usually recommended against. We have serotonin-related antiemetics that tend to be pretty effective and have just overall a better adverse effect profile for most individuals. So our serotonin antiemetics, particularly the most common one you'll run into is ondansetron or Zofran. Those will be recommended over a promethazine. Now, when it comes to screening for cognitive impairment, the U.S. Preventatives Task Force in 2020 came out with some recommendations about screening for dementia. And they really just kind of said there's not good evidence to say it's good or bad because they're looking at improvement in outcomes, they're looking at harm, and it doesn't seem to do either of those things for the patient or for the caregiver. So it's kind of an individual clinical judgment aspect when it comes to screening, specifically using cognitive assessments for dementia. So the cognitive assessments that we use are listed here, right? So we have our mini-cog, our mini mental state examination, the Montreal Cognitive Assessment, and the St. Louis University Mental Status Exam. So probably the ones you see most often would be the MMSE or the MOCA, but we certainly do run into things like the SLUMS as well. And there's usually multiple versions, including versions for people of lower education status, individuals who have difficulty seeing. So there are a variety of different versions available for that as well. Other aspects of screening include biomarkers. And biomarkers are still kind of challenging in that most of them we don't have great correlation with as of yet. So we can do things like blood tests, we can look at cerebrospinal fluid, we can do imaging. The big one that has some association that we will pretty routinely in these scenarios test for is the apolipoprotein E, or ApoE. And this comes in several different forms, or alleles as we call it, and each individual will inherit 2 alleles from each biological parent. Now, there is a genetic component to development of Alzheimer's disease. ApoE2 it's pretty rare. And actually might have some protective value against Alzheimer's. So it'll kind of prolong the time to symptom onset. 3 is the most common allele, and it's kind of neutral. It doesn't seem to increase or decrease risk. However, ApoE4 does increase the risk of developing, the standard late stage Alzheimer's, although it will kind of move it to be a little bit earlier. About 25% of people will carry the ApoE4 allele. Okay. Now, one thing to take notice of, though, is it's a risk factor gene. So it just increases someone's risk of developing the disease. However, it doesn't mean that the person will develop Alzheimer's. And that's where the challenge kind of comes in. Some people with this allele will never get the disease, and people who don't have the allele will sometimes develop the disease. Now, there are a couple precursor kind of proteins and other biomarkers that we can look at, so amyloid precursor protein and presenilin, that are associated with that earlier onset of dementia that will sometimes get tested for. But really, the ApoE is the most common one. When we look at things like PET scans and MRIs, we can do imaging that will look at changes in the actual brain structures that can be helpful for evaluating someone's dementia. Plasma tests are still fairly not super useful. So we have like tau proteins and signs of inflammation that we can test in the plasma. And then if someone's doing cerebrospinal fluid testing, they're usually looking at those amyloid beta ratios or instances within the CSF, as well as tau proteins. We do see these neurofilament light chains, which are associated with neuroinflammation. So there's some association there as well. But we'd really just be looking at the A beta 42 ratios and the tau proteins as correlates to evaluating the cause of an individual's dementia or cognitive impairment.